Yes, thank you, sir. So I would ask Dr. Binayak Sinha to start the presentation.
Uh, Thank you for asking me to be a part of this program. Not only is it a chance to speak to people all across the world, but it is also a chance for me to meet in face to face, albeit on virtual medium, with some very close friends who I'm really seeing after a very long time. And all this by virtue of a small little piece of fact called COVID-19, which has changed the entire narrative of the way we look at life. Life before and life after will never be the same again. And one of the important issues in this COVID-19 pandemic, which has cropped up repeatedly, is the question of diabetes. So I will be talking very briefly. I think I've got about 10 slides talking about diabetes and COVID-19 and the interplay between them. So um, today's status in India, I just thought I would show you because most of the people are from India. So you will like to know that this is the situation in India. So this is the total number of cases, about 30 million, about 447,000 are active. A total of 29 million plus have been discharged, and about 400,000 fellow citizens have lost their lives to this deadly virus. So with that background, why does diabetes feature so often in hospitalization? Why is diabetes so important? And this is something that comes up again and again as to why diabetes is such a important point in any kind of medical discussion, not withholding the fact that diabetes is often known as the mother of all diseases. So with that in mind, I show you some data which is very interesting. I will be talking very little medicine as such. So people who have diabetes have a very high risk of hospitalization, about 2 times, and even people with pre-diabetes, people who have, say, a risk of developing diabetes will also develop a risk of hospitalization. This is regardless of COVID. So people with diabetes are susceptible to infection, and people with diabetes will be hospitalized more often with infection than somebody who does not have diabetes, to the extent of about 3 times more if the blood sugars are not controlled. Now, with that in mind, we move on to another thing to look at, of course, the infection of COVID-19 and diabetes. Now, one of the things is this SARS-CoV-2 virus causes beta cell damage and cytokine storm, which has an interplay with worsening metabolic control in patients with diabetes. There is worsening hyperglycemia or high blood glucose. It may also lead to new onset diabetes, and somebody who is well controlled might actually find that COVID starts to make their blood sugars go up. And this, I'm sure, across the world, all of you will agree with me. We have doctors from UK here as well, who will agree with me that 2 things that have really pushed COVID to the status that it has is the risk of death really goes up with obesity, high blood sugar, old age, and heart disease, along with kidney disease. The other factors like inflammation and coagulation are, to be honest, very theoretical factors, very things that still are in the realm of mechanistic studies. But there is no doubt, if you ever have been to a COVID ward and if you have ever noticed your patients, you will find that the people who have poor outcomes are people who are obese, people who are diabetic, people with heart disease, people who are elderly, and people with kidney disease. So this is the reason why we are so careful about diabetes, because diabetes is almost a sine qua non with obesity. And what is worse is if you have poor diabetes control, the risk of severe infection is higher. Now, this is a very small little plot. This is the only medical chart, I promise you. And it shows you that if you have a HbA1c, this is the HbA1c on this side, and till 7 is good. So if you have till 7, you see that the dot is to the left of unity, which means there's very little risk. The moment it goes above 7, you find that the risk starts to increase. The moment it goes above 8, which is worse, it goes even higher. And if you have it more than 10, which is very high blood sugar, you will find that the risk of developing any kind of severe COVID or complications from COVID thereof are going up almost exponentially to the tune of 2.25 to 50% in patients with diabetes. So we need to keep diabetes in control because it does not only cause severe disease, it increases mortality. This is data from China showing people with diabetes having 7 times the mortality of people without diabetes. Again, in Italy, 5 times almost, and in New York State, of the people who died, about 40% who died had diabetes in October 2020. So it is very serious, and therefore diabetes control is necessary. But along with all this has been an impact of lockdown on diabetes. And we looked at a mathematical model of estimation of what the lockdown did to glycemic control and how it would lead to diabetes related complications. And if you look at this, you'll find that people who were in the lockdown had a worsening of HbA1c, which would lead to worsening of outcomes from the kidney and the nerves and the eyes, as well as a slightly increased risk of heart attacks, strokes, and infections, even during a short period of time, just by virtue of the fact that they had diabetes. So diabetes control, regular visits to the physician, regularly taking charge of your levels is important, because it is shown that if your diabetes is well controlled, your chances of survival are almost 100%. Look at this chart, which is at almost 100%. And if you look at people who are poorly controlled, it immediately comes down by 5%. So if you do not have good glycemic control, if you have high blood sugars, your chances of dying from COVID is much higher, and that has been proven. So the august bodies have all taken it into cognizance, and this is the American College of Endocrinologists, the American Diabetes Association, the International Federation of Diabetes, the Research Society for the Diabetes have all mentioned that if you are going to protect yourself from COVID, the most important thing is you have to make sure, in addition to the usual non-pharmacological measures and vaccines, which my colleague Dr. Mukherjee will be talking about in a while, you have to make sure your diabetes is well controlled without fluctuations, and make sure that you do not relate, that diabetes does not lead to any of the complications that can arise from COVID. So what do? We make people aware of this. We optimize therapy. We make sure medicines are available. In the first wave in India, there was a big problem with medicines being available. That led to a lot of discontinuation of medicines, leading to worsening outcomes. We should utilize telemedicine and other health models, if possible, to maintain good control. Any kind of medicine is okay. You can use any medicine pretty contusively to maintain good blood sugars and an HbA1c of 7%. For people on insulin, you should avoid hypoglycemia and maintain your time in range. And if you do that, the chances of COVID affecting you and making things bad for you are pretty much low. So to conclude, diabetes is a risk factor for severe COVID-19. Glucose control, if you do it well, you will do well. Management needs to be modified as per the severity of COVID-19 illness, and that is more of a medical issue rather than an issue which would interest all the laypersons here in this audience. And the management of hyperglycemia would depend on the level of hyperglycemia at admission. Bottom line, look after yourself, stay in control, and make sure that your diabetes does not run away from you, to make sure your COVID doesn't cause any problems. Thank you very much for listening to me. Thank you for your patience. I will take the questions and participate in the discussion now, as I will have to leave after that.
Shall I ask the panel members? Is there anything that you want to ask?
Can I ask Vinayak? I love asking questions to do anyway. How did you deal with your diabetic patients who were infected with COVID? So, did you?
I think it was a real uphill struggle. I think if somebody has mild or moderate COVID, they can usually stay on the elder line. Yes, I think somebody should mute themselves.
I think Debashis.
And Tutul, mute card.
Dala. Sorry.
Hello. So for mild to moderate COVID, you can continue on the usual medication. For the people who are in hospital, a combination of diabetes and a combination of steroids leads to a complete explosion of diabetes.
Yeah.
So, you know, there is no option but to use insulin in very high doses. And, you know, the standard treatment for such things is the basal bolus diabetes, the insulin regime, and there's no other option to it. And it is a very uphill struggle. It's a very uphill struggle.
I also want to make a comment. I used your paper to inform our cluster. So general practices in the UK are clumped together in clusters. So we fall into Cardiff South and West. And we have a very mixed population with a high Asian population, really high diabetic morbidity per capita in our population. So your study was used actually to help inform how we as a cluster kind of go about it. So even though most people had stopped testing and monitoring chronic disease during COVID, we made sure that we had a hot hub where we could keep doing the blood tests, regular texts and stuff like that. So no, thank you.
Thank you.
That was really useful.
Binayak, I have two comments. I mean, actually one question and one comment. First of all, I mean, the role of steroids. I mean, as you see in moderate to severe COVID, we all give steroids, and whether you are seeing, I mean, more diabetes because of these steroids as well, and whether they are unmasking the latent diabetes. And secondly, what's your experience about seeing not diabetes, but actually hypoglycemia post-discharge? I've seen a few patients, I mean, who are having a sort of lowish blood, not classical hypoglycemia, but sort of lowish blood glucose levels. Your views on that?
So Suranjan, I'll take your first question first. So yes, steroids have really lifted the mask of many people who probably had pre-diabetes or had undiagnosed diabetes. And actually, there's a surge of patients in the OPDs and clinics, and on telephonic consultation. All these things, there's a complete surge of patients. Also, I think COVID actually affects the pancreas, and it leads to a different form of diabetes. I'm seeing quite a few young people who are coming who require insulin, and they, from the very beginning, they've been on basal bolus, and they have continued to be on basal bolus even after discharge, and showing the typical features of type 1 diabetes. So that is one aspect that we are seeing. As you know, Suranjan, that in India at least, the number of people we see in our outpatients with type 1 diabetes, say in a day I would see one patient. But so it's quite a shock really to see so many type 1 diabetes patients coming. The second thing is this hypoglycemia. Are you talking of patients who are on anti-diabetics or without anti-diabetics?
I mean, some were and some weren't. That's why. I mean, I knew
so
to ask this question. Yeah.
So, Suranjan, there's quite a bit of evidence which is evolving, particularly from America, that diabetes is not only not the only endocrine disease that's being unmasked. There's quite a bit of thyroiditis. I'm sure you're seeing a lot of people coming with throat pain, and if you really look at them, Dr. Shengupta's clinic has thrown up at least 4 or 5 thyroiditis in the last month for me. So it's pretty common. I think there's growing concern that it might be also affecting the adrenal gland, and that might be leading to some degree of hypoglycemia. No concrete evidence as such, but I think it is evolving data, and we look forward to more data on this. I hope it will come out soon. But it is something that definitely affects the glands.
You mentioned about the type 1 diabetes. I mean, you're sort of seeing more type 1 diabetes post-COVID. Is this reversible? Say the beta cell damage by the virus.
I don't know. There's a paper which has come out from the United States, which says that this is due to beta cell apoptosis in the pancreas. And this is directly related to SARS-CoV-2. So I honestly don't know the answer to this. The data is still evolving. You see, this is what happens during a pandemic which is unraveling. You know, data is always in progress, and we have to wait. And you know, we in India at least have seen the outcomes that can happen for not waiting for data to come through. And so I think we have to wait for the data.
Binayak, can I ask you something? You know, during the second wave, I think first wave, I think diabetes control was not the top of the priority, because I think at that time, around March, April time, in UK at least, people were still trying to understand the disease, and there was a lot of emphasis on the hypoxia element of the thing rather than anything else. During the second wave, diabetes became quite important, especially because of the steroid use. And early measurement of ketone became a standard. So anyone who was being started on steroid had their ketones checked very early on and started on a sliding scale. Are you doing anything similar, or anyone who is being started on steroids, or just managing the blood sugar?
So that's probably natural, Raja, because you see, in England, the number of people you would see with type 1 diabetes would be higher. That is my ballpark estimation. Now, we as such have this protocol in our hospital. Mind you, there's one thing. You have the facility to measure serum ketones. In India, serum ketones are still very difficult to measure, and it is still a very expensive test. So we depend on urine ketones, and as you know, urine ketone is exposed to a lot of fallacies. So I don't know how good they are, but our hospital, the protocol is anybody with a blood sugar of more than 250, which roughly translates into something like about, say, 13, I think, millimoles, would have a urinary dipstick of ketone. But, you know, I have to say, I think we particularly focus this on quite a few young people who were admitted. We picked up 2 or 3 young people with type 1 diabetes, which is expected. One was 18, one was 21. And there was another one who was 21. There were 2 girls who were 21. And but there were quite a few elderly people who had ketones. But see, in this rigmarole of managing COVID, at that point of time, you don't work up this, whether this patient has type 1 or type 2 or MODY, or, you know, everything is lost at that point of time. You know, you're just interested in just doing things right then and
Thanks.
I think what you mentioned about adrenal damage, okay, from the community, all I see are people before they go in and people thereafter. But certainly a few people who've survived pretty bad SIRS have come back with necrosis to the adrenal glands and are pretty flat and Addisonian post-COVID. And these were picked up because they presented with thinking they had long COVID, but actually it was really how
that's pretty
Addisonian.
clever, actually, to think of adrenal insufficiency. I think that's very clever. You know, I'm very interested to take questions from people who are not doctors. If you have any questions, you can please ask them to me now, so that I can. I'm really more interested. The doctors here are all good friends who are at the end of a WhatsApp all the time. So
I think we have a question there.
I think there's a question which says that.
Debarati, Debarati, is there anything that you can see? Because I can't see anything, any other questions.
There's one question from Dr. Shobhusha Chaudhuri. Does everyone suffering from COVID get their blood sugar tested?
Yes. The rule of thumb is diabetes is such a pandemic that, you know, if you have a blood test, check your blood sugar as well.
All right.
Can I request the audience to please ask questions to Dr. Binayak Sinha, because he will be leaving soon. So any questions related to diabetes and COVID, please feel free to ask now. You can raise your hand or ask in the chat.
You can even unmute yourself and ask. It's absolutely fine.
I have a question. Can I ask a question? This is Gagan from Delhi.
Please. Yes, Gagan, please.
Yeah, I have diabetes from last 6-7 years, and I tested COVID positive on around in the first week of April, and after after getting all right, I'm feeling my eyes are a little more weak. So is it due to diabetes and COVID or something else? Can you please guide me what to do?
No, are your blood sugars under control?
My last HB1C, which was tested a month back, was 6.8.
Okay. So I think as a diabetic, you need to have a yearly retina checkup. So please go to your eye doctor and have a checkup done immediately.
Sure, sir. Thank you so much.
Thank you.
May I just take this opportunity to add one note, though, that it has been identified that the risk associated with diabetic retinopathy and COVID, they found that there's such pre-existing damage to the blood vessels result in more severe COVID infection requiring ICU management. So this is something we have seen in our hospital, that the people who had diabetes, who had come with COVID infection, after the discharge, because nobody's bothered about other complications than, of course, the lung and the heart, and of course the kidney. We have seen that they have almost 7 times more retinopathy, the existing population who came in. So may I also plead Gagan to make sure that he goes back and checks his retina, as Dr. Sinha advised. So retinopathy associated with 5-fold risk of intubation as well. So this is direct connection of diabetic complication to the COVID severity. Thank you.
Wow. Thank you.
That's pretty powerful information, isn't it? The question is it selection bias, or is it so were the people already poorly controlled?
I think poorly controlled diabetes will have poorly controlled retinas. So that is the easy answer, because only poorly controlled diabetes will be ventilated.
And Sheila, এটা কিংস কলেজেরও ডেটা আছে, দেখিস ভালো করে, মানে কিংস কলেজ থেকে এসেছে।
This is quite interesting, কিন্তু thank you.
Dr. Binayak Sinha, can I ask a question? And this is regarding thank you. And this is regarding vaccination. Do you think the vaccination, the efficacy of the vaccination will have the same effect for a patient with diabetes as with that of a normal patient?
So I think you make a very moot point out here. I think there's going to be a talk on vaccination from literally an expert in this field just after this, but I'll put you in my 2-penny bit. As of now, we don't have enough data with vaccination to actually say that this works, this doesn't work. But I was reading a New England Journal of Medicine editorial just about 15 minutes before I started this talk. And it says that till now, there is nothing to say that vaccines have less efficacy in any group against any variant in any part of the world. It is all good. So today, unless you have an allergic reaction to the first dose of vaccine, please go ahead and take your vaccine. And I reiterate this to my patients, and I say it as a bit of a tragedy that after the first wave, when I was doing my OPD, I kind of did an audit of the people. Only 2 out of 10 of my diabetic patients actually took a vaccine. And look at what happened to India. I think Miku and I had a bit of a discussion one day while chatting on this.
Yeah, I mean,
whereas
Binayak and
now Suranjan bolche bole Nick. Now what I wanted to kind of prompt again, that whereas CDC and of course our ADA etc., they all significantly make us aware that these are the following vaccinations: MMR, Diabet, DT, plus pneumonia vaccination. Initially it was said above the age of 2 years, if you're a diabetic, then you should take a shot. Now it is talked about 18 years. Influenza, of course, once yearly, herpes virus, and hepatitis B. So these were mandatory. And if you remember, though, we had published in 2010, we had done around 7,000 vaccinations. It was initially ridiculed. Ridiculed in the sense people were saying, why vaccination for diabetes? Because much before that, ACIP said and ADA was hinting. And we saw that classically people with diabetes, they have pneumonia, and from the pneumonia, 85% of them land in heart failure. And this is all, silent. This is all because of the endothelial, basic endothelial damage. So keeping that in mind, when we were basically hinting and actually driving home the immunization of all these, kind of so-called diseases, why are we delaying it on paper? Why are we not kind of promulgating such a strategy on behalf of the government or from our regulatory bodies or the bodies that we have within us? If you are a person with diabetes, if you are a TPWD, you must be vaccinated. It's as sacrosanct as that.
Totally agree with you. Suranjan.
Type 1, type 2.
I think now it's just read this report. I think it came up in Nature about this Lambda variant. I mean, from Peru. Any comments, Miku, on that? I mean,
I think Rajada will have better figures, but I haven't yet come across any. We don't get to know what variant our patients have. The opinion here is it's still very much one of concern because of the fact that the spike protein is very different. So it may...
No. I think the Lambda variant is still one of interest, not of concern.
That is right. It's of interest rather than concern, sorry. But it's probably going to turn into one of concern is the opinion, because people still don't know. But till now, like Doe said, absolute. When vaccines were really pushed through, they said the minimum effective efficacy would be 50%. All the vaccines are way better than that. And for all the massive amount of news and fake news of complications, both real and imagined, that's minuscule compared to the dangers of COVID. So, like, I have been sending people messages, bombarding them with texts, because I know which of my patients have not taken the vaccine. So from certain communities, there was vaccine hesitancy, but after repeated bombardment saying that this is true, this is not true, this is true, this is not true, the national hesitancy rate, so 86.9% of those who could get the vaccine in UK got their first dose. For our patients, even though we had a very difficult ethnic mix, it was actually well above 95%. So it was just continuously trying to inform them until Chocolate had the vaccines.
So is it a variant of concern or a variant of interest, Mane?
Still a variant of interest.
As of today, it's interest.
Yeah, it's still a variant of
interest. But the concern is, I mean, it has spread to, I mean, it started from Peru. And also, Hungary has been affected as well. But I mean, the authenticity needs to be verified.
Yes.
And there's some prediction that it's going to UK as well.
It's already made landfall.
UK, it has come. It has landed.
But
It has landed. I mean, but we don't know with what variant that is. Do we have that sort of genetic information?
No.
8 cases. 8 cases in the UK, which have been genetically.
Okay.
The way
But just একটা কথা বল, I mean, would you establish the fact that it is scarier than much more scarier than alpha and gamma variants?
I think that's going to take time, isn't it? I mean, people are just trying to starting to find out. We don't know enough.
Okay.
But the point is, the way any virus seems to evolve, it starts to get more and more transmissible. But the natural history of a lot of viral disease is that ultimately it becomes more transmissible and less dangerous for it to be a successful virus. Am I sounding a bit dangerous? But my hope is that in due course, there'll be more transmissible but less dangerous forms of COVID around.
Like our own flu virus.
Yeah. So just to put, this is something that I've been recently reading out of interest. So the influenza vaccine, which Tutul was speaking so much about, it has an efficacy of 40 to 60%.
It is. To put it in perspective, though, in 2018, UK got the predictions wrong, and we had 20,000 deaths from influenza in 2018. So we now give people quadrivalent vaccines. So there are 4 different types in it.
Pico, I would take this opportunity to put forward that this idea, which we had published also, IGCPT, the paper that we wrote in September, was published in November, I believe, just before the fall, because we were actually anticipating a kind of a deadly dual wave of both corona and flu. What I keep saying, and I will speak this in Bangla to my patients, that jodi flu marke amra bhalo kore jotno ni, people who have joined, in from other places and do not know Bengali, I will basically translate. But if we get to, the disease which struck in 1918, lasted for 2 years, wreaked havoc, 100 million died. We forgot that easily. That's the human memory. In 1940, it took 20 years to develop the first vaccine, and it was quite a successful, efficacious vaccine. And it took us till 2020. How many people, how many of our patients did we recommend flu vaccine here in India? In the developed nations, you ought to have a flu shot. I mean, that's the country's headache. For us, we didn't bother. For 80 years, we had the vaccine, right? But we didn't bother. And now suddenly Coronamashi has come. Flu ma and Coronamashi, just a variant, same, spike proteins, the RNA, etc., and almost look the same. And now suddenly you're concerned in 6 months' time, you're fast tracking a vaccine, etc., and you are giving the dose. You're talking about an antibody response in 6 weeks, 8 weeks. If vaccine is not available, stretch it to 16 weeks. Aren't we becoming real guinea pigs? Aren't we behaving like puppets to people who don't know anything about this vaccine, the response of the vaccine? For the common man, I'm like talking like a common man now. That what are we? The scientists or the doctors, what are we trying to project? I believe that had it been amader deshe, we would have actually, run amok and got everyone vaccinated against flu. Perhaps flu market to সম্মান জানালে, we would have put a little bit, shown a little respect to this flu ma. Perhaps Coronamashi would have come, kissed you, চুমু দিত, কিন্তু চুম্বন করতো, কিন্তু চুম্বক করে ধাপার মাঠে নিয়ে যেত না. Perhaps she would have, got the smell that, one dog and the neighbor's dog, he will not bite if you have a dog at home. So it's that kind of stuff. So I have some, kind of reservation about the kind of vaccination that has been going on. I believe these quick mutations and the variants that are coming also are a fallout of this very rapid pace of the vaccines that we developed without actually thinking that maybe there would be variants following up, and maybe these variants obviously will have low impact, but are they going to really result in that kind of immunity? Instead, if we can go, all guns blazing for a flu vaccine in this world, along with the corona wave. Don't forget, 100 million deaths within 2 years, and you have not even have 5 million now. So what is the kind of analogy? Very philosophical note though. Actually, I do a completely social different, Piku তোর সাথে অনেকদিন দেখা হয়নি, আমি একদম গ্রামে গঞ্জে কাজ করি for last 15 years. I have an organization called Diabetes Awareness in Due. তো সেখানে আমরা গিয়ে এগুলো করছি, দেখছি. We have seen plenty of DKs to the type 1 children whom we actually sponsor insulin. Amra insulin kinte parini, amra plain. I would be happy to know amra first wave সময় around August তো এইসব করেছি তখন এগুলো মনে হয় suddenly this comes to the mind বসে বসে যে এই ভ্যাকসিনের জন্য যত নাটকটা চলছে এখানে ফ্রি ওখানে পয়সা দিয়ে এখন স্পুটনিক পরে মডার্না সবাই নাকি এও ভালো সেও খারাপ এত এফিকেসি এত কিন্তু what is the actual picture? It will take time, and maybe by that time 4 years time you will never hear about Corona Mashi. She will flee from us. She has already hated this race called mankind. She doesn't want to live within us. Unfortunately, she has nowhere else to go. She has been uprooted from the guts of the bats. Sorry, Suranjan, lecture sorry.
It's all right.
I'll take your leave, friends. I have to go. Bye-bye. Take care. Everybody stay safe, stay well. Bye.
Thank you, sir. Thank you so much.
Good to see you after such a long time.
Thank you so
Take
much.
care.
You too.
Thank you. Thanks.
Cheers.
Bye.
Right.
Bye. Bye.
Can we move to the second speaker, Dr. Suranjan Mukherjee,
Yes,
consultant pulmonologist, India. The topic is myths and facts about COVID-19 vaccines. Welcome, sir.
Okay. Can we see the slides?
Yes.
Yeah. Okay. Right now, first of all, thanks a lot for giving me this opportunity to present. This talk actually is mostly meant for the non-doctor participants in this meeting. I've just tried to make it a bit sort of light presentation. It's not about the intricate details of vaccines and how they work, and I think that has been covered by Dr. Sengupta in a previous meeting. So this is just to talk about how myths evolve about vaccines, particularly the COVID vaccine, and what's the sort of facts behind them. Okay, right. Let's start then. So the first one, so we know myths are fun, but as long as you don't confuse them with the truth. Now, if you confuse them with the truth, the world has learned the lesson. You can see that when the MMR vaccine came in, and there was this myth about autism and the MMR vaccine. However, and many people were reluctant, and you can see that there was a resurgence of measles in Europe. That was data collected between, I think, 2010 and 2019 about the resurgence. So myths are always there. Whenever a vaccine comes in, there are myths associated. It comes in a sort of bundle. So CDC has come up with this framework, and one of the 3 frameworks is to stop myths. And even the CDC, Johns Hopkins University, and the WHO has come up with a list of myths that has come up with the COVID vaccine. Now, whether you can call them myths or FAQs or conspiracy theories, but I will cover them quickly. Before that, this was a study done, and they found out that in a particular cohort of people, there would be some skeptics, but in this case, COVID skeptics, who don't believe in vaccines in general, but deep in their heart, they believe that there are problems with the vaccine. And every person in this group believes that there is at least one conspiracy theory. Okay, and now there are other groups. I can see the enthusiasts, the watchful, the cost anxious, the system distrusters, and probably we can identify ourselves within one of these 5 groups. Now, if you look at these are very interesting. Now, the 17% which is shown are the COVID skeptics. Now, with persuasion, you can increase the vaccination. So it was the first survey and the second survey by Sargo Ventures. And you can see whether you can bring down the persuadable numbers, but you have very little impact on the COVID skeptics. So these group of people will always remain. And I'm showing you an example, just if you can read this post, it's taken from this RVAX happened. These poorly tested poisonous syringes filled with 72 plus different diseases, toxins, mashed up aborted baby cells, animal DNA, more poison, all in by age 18. Now, let's go. So let's move on to some myths. Now, these are very straightforward. You can call them myths, you can call them FAQs, as I said. Whether you can get COVID-19 from the vaccine straight away, no. After I get vaccinated, I no longer need to wear a mask. No, you need to sort of take the measures because vaccines are not 100% effective. I already had COVID-19. I don't need to get the vaccine. Even that, no, we don't know how long prior COVID infection gives you protection. The side effects of the COVID vaccine are dangerous, very, very, very rare. The common reactions are local reactions and a sort of mild systemic symptoms. So nothing to be scared about that. The COVID vaccine can change my DNA and contains harmful substances. The vaccine never enters the nucleus of the cell, so there is no question of changing the DNA, and the COVID-19 vaccine isn't safe. Now, these are the lists I've got from those sites, the CDC, Johns Hopkins, and the WHO. So these are sort of questions, these are sort of harmless questions. I mean, anyone can sort of ask about these questions, but the problem is, and also CDC has published some in their official site that about the answers of those two previous questions. Let's come to some conspiracy theories. I will skip that. And let's come to some conspiracy theories. Now, this is where it really gets interesting. So vaccine is female sterilization because it has been sort of mentioned that the spike protein called the syncytin 1, it's similar to the human placenta in women. So it can cause female sterilization. Obviously, it's a completely false information. So COVID vaccine and fertility, there is no impact on fertility observed. Long-term side effects, highly unlikely. Pregnant women likely to transfer antibodies to unborn child. So in pregnancy, they should be vaccinated. And clearly, there has been statements from the experts that COVID-19 vaccines can lead to infertility, and that's a myth. That's a complete myth. The RCOG and the Royal College of Midwives also issued statements about the fact that there is no biologically plausible mechanisms by which current vaccines can cause women's infertility. Next, more interesting. Now, Bill Gates is the target now. So he owns the patent for coronavirus, and he owns the vaccine, and he's also partner in the lab in Wuhan. Right. Let's see. He admits the vaccine will no doubt kill more than about 7 lakh people and has killed about 3 lakhs globally. So this was tweeted on May 21st. Interestingly, the Republicans, 44% Republicans believed in that theory that Bill Gates wants to use mass COVID-19 vaccination and also to implant microchips to track people. Something he has never said and strongly denied. Right. This has spread on social media feeds from Pakistan to Argentina, and that's a BBC News. So see how things come up. Bill Gates plot to microchip the world, Dr. Fauci blocking natural cures, and these are the anti-vaxxers. So Pentagon scientists reveal a microchip that senses COVID-19 in your body before you show. $138 million contract to Apiject Systems to provide pre-filled syringes with RFID microchip tracking system. Even you can see on the net the circuit of the microchip. Now, I'm sure Dr. Sinha might be able to identify. It was shown to be this metal zone MT2, which the guitarists use for their bands. Does it look familiar, Dr. Sinha?
Now that you pointed out, very much so, actually.
Yes.
I don't have a Boss metal zone, but I do have a Boss chorus pedal. But that is what the circuit looks like.
So, see, and how, right, okay. Now, more interesting, the magnetic effect. So it's from the Bengaluru, the woman claimed that metal objects sticking to her body after being vaccinated. Right. Jyoti Gaura took her first dose of Covaxin on April 26th and the second on May 29th. Thank God she had 2 doses of vaccines at least. More reports coming up. Forks and coins sticking to the body of this man from Hazaribagh in India. Tahir Ansari. And this is from a sort of the Bengali media. There were 3 people who were showing the metal objects sticking to their throat, to their body. Right. No, your jab isn't magnetic. Right. There is no evidence. And the BBC reality checks Jack Goodman debunks the so-called magnetic challenge. Even from the Indian Rationalist Associations, the FIRA, the Federation of Indian Rationalist Associations, clearly made a statement that no, there is no magnetic effect of vaccines. Now, BCG-based vaccine may be effective against COVID-19. Wrong. No evidence. Now, things become a bit serious. Now, the conspiracy theory now targets some religious communities. The vaccine contains pork or beef. Right? Published in the BBC, the Pfizer, Moderna, and Oxford AstraZeneca contain no animal products. Catholics should pause before taking the COVID vaccine. The Vatican Congregation for the Doctrine of Faith, the CDF, issued an alarming and misleading document that the vaccine contains aborted fetal cell lines in their testing or development. Okay, and so they have strongly sort of condemned the use of vaccines. This use of aborted fetal cell line, the technique was first used in the 1960s, and they used cloned cells from legally aborted fetus. And the UK regulatory involved with the BBC told that there was no enter in the vaccine. Last slide, right? So a cow dung vaccine. Of course, I mean, there was some media reports of Ayurvedic vaccine from cow's milk, butter, ghee, dung, and urine. But of course, I mean, no evidence. So that's in a nutshell about the myths, the conspiracy theories behind. And as I say, it's amongst a particular sort of group of people, as I have shown you, the vaccine skeptics who would like to believe, who wants to believe about these myths and theories. Thank you.
There is one question from Anirban. Shall I
Yes.
ask you? So for children below 18 who are yet to be vaccinated, can flu vaccine provide any cover?
Flu vaccine providing for COVID virus, you mean?
Yes, that is what I think he
Yeah.
meant.
No, I don't think there is any evidence that and there is any cross cover between the flu vaccine, between other vaccines and the COVID vaccine.
And there is another query from Debashis Rai. What is expected possible time that we can face the third wave? And what are the precautions to be taken? Will this third wave will be more harmful for the 12 to 18 age group? How to prevent this? Please explain.
Now, these are all calculations, speculations, predictions, which in real life might not be always right. Now, what I feel, or I will also ask Raja and Miku, that if now the prediction was that because the group, the age group below 18 weren't vaccinated or they're not going to be vaccinated, so those group will be the most vulnerable group in the third wave. My theory is, my argument against that is, they were even not covered in the second wave as well. But still, we didn't find a huge number of patients below the age of 18 who had quite severe COVID or needed hospitalization. So the involvement of the age group below 18, I take it sort of, I have some reservations for that. Is the third wave coming? Yes, it will come, but how severe will it be? It remains to be seen. Many factors are there, how people are protecting themselves, how many vaccinations have been done by then, and how much the virus has mutated. So these are all sort of the variables which will affect the severity of the third wave.
Suranjan, can I come in on a few points you have made? Because yeah. I think UK is obviously just experiencing the wave just before India. So whatever is happening in UK is happening in India a few months down the line. Yeah. So I think looking at the estimation, I think India is following probably about 4 to 6 months after UK. And,
about 2 to 3 months, I would say, Raja. Yeah,
yeah. But at the moment, UK is going through the third wave. The third wave has started in UK and it's peaking quite nicely, and it's supposed to start coming down around August time. The thing is, because of the high vaccination number, it has not affected UK this much. Like you have already said, and I think that's a very valid point, India has probably vaccinated more people than the whole population of UK. Yeah. But that only is about 10% of the
5% of the.
And till you vaccinate almost 30 to 80% of the population of Indian population, which is probably going to be sometime around middle of next year, before which it is difficult to achieve it. India is likely to have successive waves of infection. Now, at the moment in UK, what is being seen is the vaccine infection severity is very low. So people are getting the infection, but they're not coming into hospital. So in my hospital where I work in, the numbers are similar to what it was in January. In January, I had nearly 130 patients with active COVID in the hospital. Now I have only 2. So that is the difference because of the vaccination. Number 2 is there's a huge number, and I think Miku can confirm that, with children under 5 who are getting bronchiolitis at the moment. Huge number. And that is something, the question about 12 to 18-year-old, you might not get COVID, but you are going to likely to get other viruses. And that bronchiolitis is a huge factor now.
I come in on that. That's a very interesting point. So one of the wonderful advantages of, well, it's not nice for a child to go to hospital, but one of the rare advantages that they swab everything. So they look at all kinds of viruses. And I can see RSV especially just shooting up. The problem is children have not interacted with other children for a long period of time. So the normal gradual increase in immunity for a certain age group, the so-called COVID children, or the children who were born just before COVID and should have been going to nursery and onwards, they haven't had the same level of interaction as before and haven't been able to build up their natural immunity. So at the moment, work is very busy for various reasons, but one is the sheer number of children with upper respiratory tract and chest infections. But these are not COVID infections, these are viral infections. So I'm not seeing it in older children because they have residual immunity from their previous school experiences. But I don't know, but this is my take on it. My take is that social distancing, masks, and spaced out schooling has led to a whole age group of children who just have not developed the usual level of immunity due to lack of exposure to other bugs.
When at the moment, we are vaccinating at the rate of around 60 to 70 lakhs. I mean, which is a huge number, but I don't know. I mean, I don't have an idea how we can increase it further. I mean, to cover this population.
You cannot.
I think a few days ago, India vaccinated twice the total number of vaccines done in the UK. But it's just the denominator is massive, isn't it?
The denominator is massive. That's a huge problem.
Unless you have to opt for Johnson, a single dose vaccine or something
the only issue is now whether I mean more data will be coming up about a booster dose. That's very important, and again we still don't know how long the effects of these vaccines last. So I mean that will be a huge task again.
I came across something very interesting, and this is why these meetings are fantastic, because you end up doing a little bit of porashana, a little bit of reading, right? And this was raised by questions in the Nextdoor Neighbor group and another group that I'm in. The problems that people are facing in India, where they may have had one Covishield, two Covishields, or a Covaxin, and all of a sudden, a lot of countries are not accepting that as evidence of vaccine, sadly. Some of this is just political and bias, isn't it? But the point is, what do you do next? But this really good ComCov study from Oxford, where they had 800 patients and they spread them to AstraZeneca first, which is Covishield, followed by Pfizer. Pfizer first, followed by AstraZeneca, or AstraZeneca. The best level of immunity seems to be with Pfizer following the initial AstraZeneca jab. So actually people who have had maybe the one AstraZeneca or the two will actually be really well protected by a booster Pfizer jab if they go abroad and find that their previous vaccine is not effective. It's safe, first of all. They didn't notice any side effects or any increase in side effects, but they actually found with Pfizer being the second jab, a much better immune response.
That's interesting.
So I don't think that has been peer reviewed yet. That's waiting to be.
No.
There's a question from Tarun. What is the reinfection rate after COVID vaccination in India, specifically Covaxin?
It's a difficult question to answer. We don't have much data about that at the moment. But I mean, if you look at the phase 3 trials, the vaccine failure rate after 2 doses of vaccine or the efficacy rate is about nearly about 75 to 80%. So, but what's happening in real life, that's difficult for me to answer because we don't have the data now. I mean, I don't have the data for that.
After your fantastically interesting myths, I was just thinking maybe everyone after a Covaxin should just put a spoon on their shoulder and see if it sticks as an evidence of immunity.
Whether it's effective or not.
There's another question. I think it came in the news at some point as well. Is it that the third wave will affect children below 12 years age group? Do we have any such information? Another myth.
I think that was what I just said. I mean, it's very difficult to answer that if the second wave hasn't involved the children who are sort of not vaccinated. I don't know whether the third wave will target the children specifically. It remains to be seen. I mean, what I feel is probably not. It will affect in the same way as the second wave.
What about the
Anything?
safety of
No.
vaccine
Because it's
during
a-
pregnancy? The safety of vaccine during pregnancy.
Yeah, vaccines are safe during pregnancy. I mean, there is no, although the initial trials with the AstraZeneca didn't include the pregnant patients, but subsequent studies have shown, and even the CDC has issued statement that they can be safely given to pregnancy. I mean, the risks are like not pregnant.
Especially during the first trimester.
Yes, I mean, there is no sort of statement by the CDC or that they can be safely given.
They can be safely given. Okay,
Yes.
thank you.
Is there anything else from anyone?
Sir, other than vaccine, is there any alternative for the children below 18 years if they are getting affected with the COVID?
I didn't get that. I mean, please say it once more.
Because 12 to 18 years children, they are not permissible to get the vaccine, right, sir?
Here, not in India so far,
Hello?
but Israel and other developed nations have already started.
Hello.
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 Yes. Yes.
Can you listen me?
Yes, I can. I can hear you.
Sir, my question is
Yes.
that the children age group below 12 to 18 years, they are not so far permissible to take the vaccine, right, sir? But
Yes.
is there any alternative for the children to make them safe from the effect of third wave?
I think nothing has come up, I mean, in the form of vaccines, but however, I mean, those three measures, hand washing, safe distance, and these masks, I mean, that should take care of that. And they should practice that rigorously. But at the moment, there is no study showing efficacy of vaccines below 18 years of age. I think one of the companies have probably started, which I cannot remember of late, but so far, I mean, there is nothing, no vaccines at the moment.
Sir, my next question.
I think, I mean, what will be the problem? I mean, if we vaccinate between 12 to 18 years, say, which is outside the evidence, outside trials, there shouldn't be, but it's not included in the vaccination program at the moment.
Suranjan, I think the issue is, sorry, Suranjan, the issue with 12 to 18 years is that there is some anecdotal evidence of myocarditis in younger age group in United States. And I think that's where the regulators are hesitating.
I think the most important issue was because these groups weren't included in the trials. So that's why.
Yeah, you're right, absolutely.
But Zydus, I think, Raja,
yeah,
Zydus is doing a trial. Zydus, I think, they're all geared to come up with. So they will, perhaps the vaccination of children in 12 to 18 years will start by September. That's
probably.
Sir, my next question is, if any children within the age group of 12 to 18 years gets affected with COVID, is it good for them that favipiravir and ivermectin they can use?
But we are into a different topic now. I don't think there is any evidence for ivermectin and favipiravir. I have never used, I've seen about 1,500 to 2,000 COVID patients, and I have never used them. Secondly, the problem in using them is people are coming to the hospital after having taken ivermectin, and their liver functions have gone way off. And the problem is, and then we cannot give remdesivir to them. I mean, in India, we use ivermectin, but I'm sure none of the doctors over there in the UK or the US use them. So there is no evidence that ivermectin works.
In fact, Suranjan, I think the Indian Council, ICMR, and the Indian government has also taken it out of their recommendation now.
Yes, they have changed the guidelines.
There's no logic it should have worked, and there's no evidence it does work. It was also in should be in that fantastic list of myths that you had. Of all the patients, again, I've only managed patients in the community, and I've never needed to give them ivermectin or any of these agents, really. It was really a big culture shock when friends and family members and all kinds of people would ask every morning on WhatsApp, what do I do with my COVID? And they would show me a list of 14 medications they were being prescribed, including 3 antibiotics, ivermectin and remdesivir, even when they were at home. And more recently, steroids, even when they're at home.
And even NOACs.
Yes. So
the oral anticoagulants. So, I mean, there was a post from my friend, a very lovely post, that they gave the huge list of 14 medicines, and at the end say, we are treating scabies, we are treating rheumatoid arthritis, we are treating pregnancy, antibacterial infections, except COVID.
In fact, I'm just about to start a course of topical ivermectin for my own self. The only problem with wearing a mask non-stop on and off for the last year and a half is that I've developed rosacea.
Right. Okay.
So there is evidence need to have topical ivermectin.
Well, I have a question that if a person is infected with COVID, then he recovers completely. So what should be the gap we should follow for the next vaccination for that person?
There are 2 things really. I mean, if you look at evidence, it says about 28 days from the date of the COVID positivity to the date of vaccination. So there should be an interval of 28 days. But however, there are some political issues, vaccine availabilities, blah, blah. You cannot in India register before 84 days from the date of COVID vaccination. If you can register, you can get it after 28 days.
No, but I think his question is whether it's 3 months post COVID and that 8 months, 3 months, now it has come down to 3 months.
The 3 months is not the evidence. The evidence is 28 days when the patient can take a vaccine after COVID. However, the 3 months is because you cannot register in the portal before 3 months. That has come from the government.
The government rule.
Exactly.
Okay, but scientifically it's 28 days.
And if you scientifically it's 28 days. And if you look at the interval now, so it's 84 days between the first and the second dose. However, with Delta variant, we have seen that we don't get a full cover until and unless we have had the second dose. So strategy should change. And even I think the BMJ published a paper, if I remember correctly, Raja and Miku, that this spacing should come down, and it should be the sort of like previous the original trial, which showed 28 days to get the people fully vaccinated. Because what we are seeing is that the theory was that vaccinate as many people as you can, at least the first dose. So that was the strategy. But with the Delta variant, I think that strategy might not work, because there is not enough protection after the first dose.
Okay. So I have one more question, which I face very frequently from the whether the lactating mother she's safe to take vaccine or not.
Yes, I've just shown in my slide that if you vaccinate them, they can pass the antibodies to their sort of yes.
All right, thank you very much.
Suranjan, what is your take on the third vaccine? I mean,
The third
whether
vaccine.
10 months later extended up to. You talked about BMJ, so
I'm very pro about it.
Acha, ठीक আছে.
I am very pro about it. But let's wait if when studies come up. Miku mentioned about this non-peer reviewed report on 800 patients.
That talks about 45 weeks and after the second increase antibodies, etc. Yeah. Good.
There's another interesting paper. So I don't know whether people present with much long COVID in India or not, but here
they do.
Yeah.
That is the picture now.
And that is a huge issue, isn't it? So you first get people to survive COVID, but then you deal with really difficult long COVID problems.
Long COVID.
Here, it seems to be 8% of all my COVID positive patients. And that is roughly the UK experience, 8 to 10%. How long it varies? About 80%. I'm just roughly telling you from a quick search of my patient population. 80 to 90% are settled by the first 3 months, but sadly 10% aren't. Caucasian ethnicity seems to be more prone to long COVID, and also women more than men in my patient group, and also the UK average. There's a very interesting but very short group of patients that I found where they were using Moderna as an early booster shot, because this concept was that you have dead virions or virus particles which are triggering a prolonged immune response causing the symptoms. And apparently this booster shot was clearing that up. But I didn't read anything more about this paper. And I'm always very suspicious when somebody says something and then nothing is published. But there's certainly this residual group of patients who have unexplained recurrent lymphadenopathy of the neck, tonsillar type of swelling, almost MIS symptoms that you're seeing in children, but skin manifestations in their feet. Seem much more of what in UK we traditionally call chilblain or frostbite post-COVID. But the main problem is that they're not being able to return to work or stay back at work because of fatigue and difficulty to concentrate.
The brain fog.
Answer.
Yeah, I think Bigu, the neuropsychiatric symptoms are getting more and more severe as we are going by the day.
Yeah.
In my practice, my own clinic practice in Gorihat and my Apollo practice, where I just get to see those patients with high sugar numbers, I think we have seen almost around 4,000 patients by now, and 40% or more have now, one post-COVID symptom like fatigue, that persistent breathlessness. This is continuing, and the nagging problems, mind you, is jeopardizing the entire family. They're always on the tenterhooks. They're completely so. Either the spouse or the children, they're always so anxious that it's not only him or her who is suffering, it's the entire family which is suffering.
Yeah.
So this is more of a family problem now. And this is going to have a toll on the other metabolic and all the cardiovascular, renal risk continuum. This stress, this stress that I'm talking about.
I mean, I'm going to go to the surgery after this because it was so busy the last few days that I didn't finish my referrals and things like that. So
I think,
one of the things that is having to make 2 urgent psychiatric referrals. There's a really high incidence of this. Shudipta, who's here, had organized a talk where he had kindly asked me and Shobhashachi, who's to talk about the psychiatric impact of COVID. Also, out here, because Indians are very reluctant to present, especially Indian men are very reluctant to present with psychological problems because they have this sense of taboo. They present very late. So we did another awareness talk over here in Cardiff for the Indians over here. It is shockingly common. Loss of jobs, loss of employment, and a total loss of self-esteem add to that as a result of COVID. So a Bhishon problem, it's massive.
ठीक.
I have a question. I have a question regarding the role of antibody titer, checking the antibody titer post-vaccination after the same duration of gap in two individual patients having a drastic difference. I mean, someone is having 1,000 or 2,000, someone is having 7,000, and the patients are getting anxious, saying that I have high antibody titer, but he has low antibody titer. And they are getting anxious about the immunity efficacy, and that's all. So what is your take about the antibody titer at all? Is it necessary or not?
It's a question for Suranjan.
It's a question to the panel or me?
Yes, Dr. Suranjan, sir.
Okay, right. Now, yes, there are sort of various antibody titers available in India. Now, it's not very clear whether they actually indicate a protective response. Again, different labs do it in a different way. There is no standardized method. So not surprisingly, you can find sometimes low titers even after 2 doses of vaccination. So I don't think that should be relied very much upon. I think patients, it's not generally prescribed by the doctor. The patients just walk into the lab and it's done. Miku, do you
exactly. It has not been prescribed by doctors.
Sorry, you were saying something?
No.
Yeah. Do you routinely do titers? Antibody titers?
Not at all. For the same reason that they are not yet standardized.
Yes.
If they're not standardized, they can be very misleading. I would love to know what my titer is, because I am traditionally a non-responder to hepatitis B vaccines. When I came to the UK, I found that I had not responded to polio and chickenpox either.
Me too. I mean, non-responder for Hep B.
Yeah, so some of us don't. And I've just been extremely careful, like I'm sure you have, Suranjan. So I would love to know, but if it is misleading or variable, the test, then it's more harmful than good to actually prescribe tests.
Okay, thank you.
Can I ask you a question somewhat related to this? In terms of non-responding, if a person doesn't have any reaction or side effect whatsoever after the vaccination, is that correlated to, or is that a sign that the patient might be a non-respondent, or any further tests are required? Like absolutely no side effects?
There's no evidence about that. That if you are having a reaction to a vaccine, then that means you are responding to the vaccine. And if you're not having a reaction, no, there is no evidence for that. There's no studies have sort of established that. So it doesn't mean.
So basically, you are saying that some patients may respond and some may not respond. I mean, they may not show any signs after vaccination. I mean,
that people who are sort of getting, say, local or systemic effects, thinking that, oh yes, the vaccine is working. It can mean, I mean, it's just so. But there's no evidence that if people are not getting any reaction at all, the vaccine isn't working. No, it doesn't work in that way.
Yeah, but
so it's quite
Piku,
yeah,
Piku, I have a question. Piku, Suranjan, Raja, everyone. The natural question from a patient that came up, where lies the importance of a vaccination finally? If you don't see that neutralization titer as an important predictor of the vaccine efficacy, for your future guidance, then how would you, look at protecting yourself from the infection, as it obviously it wanes with time. You need to do it every year or every 9 months. What will be the, kind of your personalized medicine or precision medicine wise, your particular choice of your next vaccine? If you're looking at the so-called deadliness, quote unquote, of the disease, and you're wanting yourself to be protected from, then we ought to have a guideline where we need to see a titer, neutralizing titer, and show us, which will guide us exactly what will be our next shot. Don't you think that way?
But if you look at the vaccines from other disease, we never check titers. We don't check titers for flu vaccine. We don't check.
It was all these vaccinations which came and which came into vogue. Before that, we had enough a good time. Never was such a fast tracking ever happened in the world. So I'm talking about that 50% at least protective titer, which is important to estimate. Did we have that time? Or still
we don't know which titer. At the moment, we don't know which is actually the protective titer. First of all, which antibody protects? We don't know what's the sort of titer it should be.
But we now know after 80 years that, say for example, after influenza virus vaccination, the protective efficacy is thought to decline by around 7% by the month, per month. So effectively 12 months around 85% chole gelo, you need to have another shot. So এইগুলো তো আমরা বলতে
ইনফ্লুয়েঞ্জা ভ্যাকসিন আমরা 85% এফিকাসি চলে যাওয়ার জন্য অ্যানুয়ালি রিপিট করি না। We repeat that because of the mutation. Because
next variant যেটা আসবে
every year. আমরা কিন্তু যে ভ্যাকসিন এফিকাসি চলে
প্রোটেক্টিভ এফিকাসি রাখতে হবে। তা নয় না, আমি বলতে চাইছি যে 50% এফেক্টিভ মিনিমাম রাখতে হবে এবং তার সাথে ভ্যারিয়েন্ট আসছে সেই মিলিয়ে একটা to be on the safe side, that was the logistic kind of model calculation, মানে একটা কনফিডেন্স ইন্টারভ্যাল নিয়ে করা হয়েছিল।
Can I just say, Amar, I really like your question, কারণ as you initially said, Vinayak's talk শেষের দিকে, that you are asking questions that intuitively a patient asks as well, isn't it? এখন মুশকিল হচ্ছে, the whole thing has been forcibly rushed through because of what was perceived as extremely dangerous infection, and we saw that in maybe the West had a more vulnerable population initially, but we saw whole nursing homes and other places getting completely wiped out. So there were actually very high death rates. So UK to chotto desh, it has an incredibly high death rate in those terms because there was that vulnerable group. As they say, the proof of the pudding is in the eating. There is no doubt that death rates have dropped massively since the vaccination has started. So yes, it is protecting us. Now, you could also argue that the vulnerable people have already died. Therefore, they're not going to die again. That is the other point of view, right? But it does seem to be protecting a lot of people. So for an example, the nursing home that my practice catered for, we had a meeting before the lockdown came in UK, and it locked down effectively. So they only had 3 deaths out of 200 patients. Now that compares incredibly well with a usual nursing home of elderly patients. Now that they're vaccinated, they haven't had deaths in the second or third wave. It does seem to be protective. It's still too early to know what the titers mean. Different tests are throwing up different titers. So there have to be studies after 3 months, 4 months, 6 months. I think there should be more studies. I was talking to my colleagues. As NHS workers, we've all been vaccinated early. They should have just enrolled us onto a titer study, because that would be great. I mean, we would have all happily agreed to have a blood test every 6 weeks so that you had a large group of patients where you could find out what was happening. So that knowledge we need, but I think only time will give us that knowledge. I think.
Okay, with your permission, I mean, am I allowed to leave?
Yeah, Sumita, I'll also leave.
Okay, I don't think there is any more questions to share at the moment. So thank you, everyone. Thank you for joining me and joining the team. I have just shared my Gmail for the UK and India and for USA, those who are interested to send some other questions. I have got few from the last webinars as well. I have shared with the doctors. So please, you are welcome to send any queries, and I will definitely see through that. Thank you. Thank you, everyone.
Thank you.
Thank you
so much.
Thank you, Sumita.
Yes,
for giving me the opportunity to at least see Piku and Raja after 33 years.
Oh, thank you. Thank you so much. Thank you. That's nice.
Take care. Bye.
Thank you, Dr.
Bye.
Mukherjee. Thank you, Dr. Sinha.
Bye.
Thank you, Dr.
Thank you.
Thank you.
Thank you.
Thanks. Thanks, Debarati.
Chalo beroi.
Thanks.